Hello, I'm Annette Dobson from the University of Queensland. I'd like to start by thanking the organisers and sponsors of this conference. The purpose of the project that I'm going to describe was to produce information for the Australian Department of Health on the effect of multimorbidity on the use of health services. Multimorbidity is the occurrence of two or more chronic conditions in the same person at the same time. The prevalence and trends of multimorbidity depend on three factors: the study population, for example, multimorbidity is more common in older people, which conditions are considered, and how the diagnoses are ascertained. For this project, the study population are participants in the Australian Longitudinal Study on Women's Health. The study started in 1996, involving 3 cohorts of women. They were randomly sampled from the Medicare database, which is the Australian Universal Health Insurance System. They lived all over Australia in urban and rural areas. The youngest were born in 1973 to 78, so they were aged 18 to 23 in 1996. The next cohort was born in 1946 to 51, so they were aged 45 to 50. The oldest cohort was born in 1921 to 26 and were aged 70 to 75 at baseline. In 2012-13, another cohort was recruited. They were born in 1989 to 95, and so they were aged 18 to 23. At baseline, there were between about 12 and 17,000 women in each cohort, and they've been resurveyed at regular intervals, about 5 to 10 times, depending on the cohort. The conditions chosen were those responsible for the greatest burden of disease, according to the latest report from the Australian Institute of Health and Welfare. The conditions are listed here. The leading causes of burden differ for different age groups. For example, depression and anxiety and back pain are predominant for the younger women, while stroke and dementia are important for the oldest group. Record linkage was used to identify the diagnoses. The data sources were self-reported in the regular surveys, hospital admissions, medical benefits scheme, the pharmaceutical benefits scheme, cancer registries, death certificates, and assessments for aged care support. The linkage keys were either the Medicare PIN numbers or the personal identifying information such as name, date of birth, and address. For each woman, all relevant sources were searched for each condition, and the source and date of any occurrence were recorded. Usually, we found multiple records indicating the woman had a condition. For example, a hospital record for diabetes, multiple HbA1c records in the Medicare data, and metformin prescriptions covered by the pharmaceutical benefits scheme. For the next step, here's a simple example for one condition: any cancer except non-melanotic skin cancer. The data aggregated across women and represent cumulative incidence or prevalence of a cancer history at each age. The percentages are almost identical for the youngest 2 cohorts, even though they were born 16 years apart. In fact, you can hardly see the red line under the blue line. The trajectory continues for the next cohort, that's the green line, as they age from their mid-40s towards 70. But there's a discontinuity between cohorts born in 1946 to 51, that's the green line, and those born in 1921 to 26, the mauve line, at the age of 70. This might be due to improvements in early detection and treatment for the baby boomers or the green line, or it may represent survivor bias in the oldest group, so that only the healthier women joined the study in 1996. The next step was to calculate how many women had multiple chronic conditions at each time. This was done separately for each cohort, as the most common conditions differed between cohorts. The top left panel shows the number of conditions experienced by women born in 1989 to 95 over the age range from 18 to 28. Excuse me. The pale color at the top indicates no chronic conditions. The next darkest color indicates one condition, and so on. For this cohort, very few women had 3 or more chronic conditions. Contrast this with the panel in the bottom right corner for women born in 1921 to 26, over a period when they were aged in their 80s and 90s. By the end of the period shown here, very few of the women had no chronic conditions, and almost 10% had 5 or more conditions. Record linkage was then used again to obtain health service use data for each woman. These were then averaged over women with the same level of multimorbidity. Here are 2 examples. The left panel shows the average number of general practitioner visits per year by women in their early 90s. They ranged from a median of 6 for women with no chronic conditions to 17 for those with 7 or more conditions. The right panel shows the number of pharmaceutical prescriptions filled per year for women in their mid-60s. Medians ranged from 6 for women with no chronic conditions to nearly 60 prescriptions per year for women with 5 or more conditions. So in summary, record linkage was essential for identifying women with medically documented chronic conditions, for looking at trajectories over time, calculating the prevalence of multimorbidity, and describing the effects of multimorbidity on the use of health services. So thank you for joining this presentation. I'd be happy to answer any questions by email. My address is at the bottom of this slide. Data from the longitudinal study on women's health are freely available to approved researchers, and we welcome collaboration. The details are available on our website. Thank you.